Good afternoon. My name is Dr. Eric Toring. I'm the Senior Vice President for the American College of Veterinary Preventive Medicine, and I welcome you all to today's webinar. The webinar today is sponsored by the American College of Veterinary Preventive Medicine and our partner organizations, the American Association of Food Safety and Public Health Veterinarians, the National Association of Federal Veterinarians, the National Association of State Public Health Veterinarians, and the U.S. Animal Health Association. So today it's my pleasure to introduce our speaker for this topic. Over the last 15 years, Dr. Christopher Lee has spoken nationally for several biopharmaceutical companies on immunology, infectious disease, and parasitology. He is board certified specialist in preventive medicine and holds a master's degree in public health. Dr. Lee is working towards a board certification in parasitology expected in 2025. He works on the NAVLE item writing committee within the American College of Veterinary Preventive Medicine, and he enjoys occasionally working in the ER and performing surgery. He currently is a monthly columnist at the Veterinary Pulse magazine, produces podcasts at myvetzone.com, and has co-authored Heroes for Healthy Pets Infectious Disease Handbook. Please join me in welcoming Dr. Christopher Lee.
Great. Thank you so much for the introduction. Love talking about leptospirosis. And if you haven't read it, the ACVIM has published a new consensus statement. So we'll be talking a lot about that today. It came out in last fall. So almost a year ago now. But a lot of great information, a lot of good updates. So a lot of things that we will be talking about there. We'll also be trying to add in a little bit of fun to this and some interaction. So grab your phones. There are 3 ways to join. You can type on the upper left. You can type that website into the URL that will pop you into the questionnaire. You can also go by text. The recipient of the text is 22333, and then you just text Sealy 101 to that number. Or use the QR code. QR code is probably one of the easiest ways to get through. Just put your camera up there. Looks like we're getting a lot of responses. We have a couple of hoarders out there, right? Now's the time to declare it if you want to. So had a nice range, anywhere from no pets. It looks like we're joining on. If you're thinking that you may want to join on but don't want to answer a question, I would say still try to sign in the first couple questions, because the instructions go away after that. With leptospirosis, so let's talk about it with the basics. With everyone here on the call, again, a lot of this is just basic review, right? It's a gram-negative-like bacteria. It kills almost as many people as rabies does globally, and infects a lot more than that. It's the most widespread zoonotic disease geographically, yet it's still one of the ones that is most underdiagnosed that we see. Now, I know that many of the people on the call today may not be in private practice, but imagine if you were. You're looking at dogs and cats. What would you think that you'd be running with these for lepto? How many tests do you see? And so it really kind of depends. And a lot of it depends on geography of where we live, whether or not we've seen it in the past, even the economic, right? The social economic status of the people that we serve, that can also change it. And we'll talk about some of the costs there. So this is pretty common, right? We are seeing more and more tests. There are some online that are saying, gosh, we're doing at least once a month, maybe a few. And there's a lot that are still, maybe when I see it, right? If I see that liver, kidney case, not understanding why else they're going, we'll talk to the owner about the test, but we'll talk a little bit about strategy on testing and what we are seeing out there. I think one of the biggest challenges, of course, and I think everyone on this, if you've done a master's of public health, you're a diplomate, if you're going to be so, right? I mean, the number of times we've sat there and talked about incidence, prevalence, relative risk, all those terms, for the general practitioner, there's often this feel of, well, gosh, if someone could explain to me the incidence and prevalence of lepto in my area, then it would be a lot easier for me to decide how often I should test, should I vaccinate? And I often get asked at lectures, so what is the incidence and prevalence? We generally don't have this in veterinary medicine, right? We're lucky when we have this data, but often we do not. And part of it is that the national data that is out there often is what we make up, right? We are submitting those tests. If we're not submitting those tests, and we just saw, that a lot of times we're not running them every week. We're not running them even more than a couple times a year. If we're not catching it, it's not becoming part of this data. So if we're flying blind to a degree and we do not have incidence or prevalence of this bacterium, well, then what do we do? And that's when we rely on the experts, right? And that brings us back to the ACVIM consensus statement. Haven't read it. It's out there online. It's free. If you can't find it, reach out to me. I'm happy to send you the link. It's headed up by Dr. Sykes and a lot of other brilliant minds. And it really is a bit of a systematic review looking at all the information we have on leptospirosis revolving around pets. So what are some of those new learnings that came out of that consensus statement? Well, one of the things that they found was that if you take a look at the data, and when we talk about prevalence, this is one of the areas in veterinary medicine we do have prevalence. There's a lot of studies. It's surprising at how many, but we do know that about 1 out of 3 rats globally are going to have leptospirosis. The prevalence ranges. It can be as high as 80%. But when you take a look at this, there are studies within the United States, outside. Consistently, we are looking at about 1 out of 3 rats. Now, if you've ever read Mrs. Frisbee and the Rats of Nim or been on the backside of a Taco Bell, you know that rats just don't go by themselves. There's always a little group. So if there's an area where there are rats, there probably is leptospirosis. In addition to that, the bacterium can remain viable in soil or standing water. If it's dry, it's dead. But if there's moisture, that bacterium can continue to live. It will also replicate. There was a thought that they really only replicate inside of the hosts. They do replicate a lot better and faster inside of hosts because they have access to a lot of nutrition, complex fatty acids, but they will live, replicate, and be somewhat happy inside of the soil. I kind of think of leptospirosis as being a very romantic bacteria. They want to go find a home and have children and be happy. Unfortunately, the best homes that they like are going to be kidneys. And then when they're raising their children, they're just releasing them into the urine and then out into the world. And so the challenge is that what they want to do ends up getting into things like rats and continuing this through. This is also why diagnostically, it will go from the soil, transfer either through ingestion, through transmucosally, through an open wound. It'll go into the blood. After a short phase in the blood, it will then move into the kidneys, and we will then see the bacterium into the urine. And then from there, sitting in the soil, that can be grabbed up by that small child and smelt. We also think of rats. We think of where are the most rattiest cities. This is one of the recent lists that came out. And I think the big key from this is often, I know when I went to vet school, we thought of this as leptospirosis was a rural disease. It's that big hunting dog that goes out into the fields, into the marshes. They get lepto, and then they come back. But when we take a look at so many of the outbreaks, they are within cities, right? One of the largest ones was in Los Angeles, one of the most radius cities. We've seen New York, which is also on there. Utah and Arizona have also had them. So they're not always what we think of as a rural, high amount of humidity, lots of rain. That's going to be a risk factor, but we're going to see a lot more rats and other anthroponic animals inside of cities. When you take a look at rats, rats eat about an ounce of food a day. So a large family of rats can go through a pound of food. You're going to find that much easier in the trash can behind a Long John Silver's than you are inside of, just the fields. So when we think about rats per square mile, you're going to have a lot more inside of a city than you are in a rural setting. So we really need to be changing that concept of who's getting it. It's no longer big dogs, rural settings. We are seeing higher prevalence of smaller dogs in urban and suburban settings. One of the other things that, we always have the question is, what about cats? And it's always sad to me that cats kind of get overlooked for so many things. And we do think that they are probably under-recognized. Data is still out. Hopefully, as time goes on, there'll be more studies. There's the belief that they are probably, to a degree, fairly resistant to the infection, because if you want to go out in the world and find the most readily available, smallest package of leptospirosis out there, you just go and collect a bunch of rat kidneys. So when we think about it, with the amount that cats are going to be exposed to that more so than a lot of other animals, likely there is some level of resistance, but I think that we're probably under-recognizing it for a lot of these cats. So hopefully more work will be done to look for cats and what can be done for those that do have clinical effects of that. With the serovars, there was this kind of thought in the past that canicola, dogs the reservoir, therefore they are not showing clinical signs if they have that serovar. That really is not to be the case. Luckily, if we're in private practice, most of the tests don't give you serovars. PCR does not. The in-house SNAP or lateral flow tests do not. MAT tests do, but they're not the most accurate when it comes to what serovar it is. MAT tests are fantastic to say, do you not have leptospirosis? But the exact serovar can be a little bit wanting in that. But regardless of that, whether or not you're looking at canicola or not, you could have canicola in a dog that is clinical, and you can also have something like pomona in a dog that's a reservoir. So with that, is that dog acting more as an asymptomatic reservoir or someone that's symptomatic? That's not necessarily going to be something that we can answer simply on what serovar it has. Okay, so again, this was a talk that I gave for AVMA, so that was a lot of clinical practitioners. I know a lot here are not, but what do you think that it should be? Should it be core lifestyle with most dogs vaccinated, not vaccinated? Actually do have some vet hospitals here in California that not only do they not vaccinate for lepto, they do not even vaccinate for rabies. Okay, so it looks like generally we're looking at about 3/4 of everyone here saying let's do core, and everyone else is like, maybe not everybody needs it, but a large amount, more than 50% do. And this is a very different polling. If you take a look at this same question to a lot of practitioners 5-10 years ago, I think those would almost be inverse to that. So I think as time goes on, we are getting more and more proactive for leptospirosis, leaning towards core. When you take a look at things like the ACVIM consensus, they are saying it is core. All dogs are at risk of leptospirosis, regardless of signalment, geographic location, lifestyle, or time of year. And that was, if you take a look, that was 12 out of 12. Everybody agreed that was writing the ACVIM consensus statement. This should be core. When I lecture on leptospirosis, a lot of times I also say, if I talk to a client in an exam room and they can prove to me that that dog is at zero risk for lepto, well, no, that they should not be getting vaccines, right? For that antigen. If you are at zero risk, why should you be getting the vaccine? You're getting risk for no reward. However, whenever I have see a dog and they can explain to me that this pet is at zero risk for lepto, I genuinely feel bad for that dog. That's a really bad, horrible life most of the time for a dog. Because if I want dogs to be exposed to lepto, because that means that they're living a full dog life, and we have protection. We ways to protect them. We have ways to diagnose it. We have ways to treat it. So we want dogs to be living a happy dog life. And if you are not exposed to lepto as a dog, well, that means you're not going to dog parks. You're not going to the beach. You're not going hiking. You're not going to boarding. You're not going to grooming. And your backyard is so sterile, squirrels do not want to walk upon it. That just sounds horrible to me. So I think when we think about leptospirosis, a normal, happy dog life, most of the time, the vast majority of those are going to be great candidates for a leptospirosis vaccine. The AHA guidelines, we take a look at the recent ones, they kind of say it's core-ish. They don't specifically label it as core, but they do say that most dogs in North America would be considered at risk, and we should be looking at vaccination. Similarly, CDC makes a nice statement of get your pet vaccinated against leptospirosis. This is something that I talk a lot to practitioners about, because while everyone on this call, ACVIM consensus statement, AHA guidelines, local studies, journals looking at rat prevalence, that all resonates to us. But to many people that are just pet owners, that just sounds like, I don't know, somebody said, some medical person said. But most people are aware of the CDC, and to say that the CDC does have a couple web pages talking about the benefits of vaccination, I think is helpful. I wouldn't say it's always has the information that's best regarding the vaccination and pets, but it is a very good resource for owners that maybe are reluctant to vaccinate, to say, this is a public health situation. This vaccine not only protects the pet, but you and your family as well. So what about diagnosis? Let's talk a little bit about what happens when they walk through our front doors. What do we do? The ACVIM put together a really great list. And so I would recommend, again, if you haven't already read this, download a copy. If you're in private practice, print out these tables, have them readily available. For the purposes of this lecture, I just kind of did a quick summary. Again, my recommendation from a clinical standpoint, use the ACVIM list. Dr. Sykes put a lot of work into making this very complete and accurate. Mine was just the quick, let's take a look at it version. But one of the things for me doing a lot of emergency work, when animals come in, it's honestly hard to find a dog that doesn't have one of these signs, right? If you have a pet that's coming to see you that's sick, who doesn't have vomiting or diarrhea or lethargy or decreased appetite, abdominal pain? And then there's some of these that may not immediately raise that thought, right? If you had a dog that came in for some ocular changes, If we saw epistaxis, do we automatically put leptospirosis on the list of things to screen? We need to be thinking about it, but that's one of the great things about this list. It's also for people, again, like me, in a 12-hour shift on a busy shift, I have seen 35 to 45 patients in a 12-hour shift. I don't always have time to think of this list or to look at the blood work. I often throw leptospirosis screening tests right on the front of my treatment plan. When we take a look at the number of tests, IDEX and Zoetis, their boxes, I will go through a box in a single shift. That is not uncommon for me. I will say when I go to a new hospital, I have now learned to tell people about my strategy. Luckily, where I work, everybody kind of knows me. But the first time I've been at some hospitals, they're like, Dr. Lee, we just don't have room in ISO anymore. I'm like, what are you talking about? They're like, well, this is like your sixth lepto case, and all of our cages are full. It's like, no, just treat them as normal. Let's run that test first before we start doing it. We need to be running these diagnostics on all these patients that may fall within these clinical signs. When we take a look at when we're looking at adding in the signs plus what we're seeing on the blood, we want to have two or more of these clinicopathologic changes. Again, I've made a nice little summary, but go to the ACVIM for the list to print out at your hospital. And again, when we take a look at this, between this and the clinical signs, it's just so vague. I end up running leptospirosis. Again, I will run through a box in a shift. It's very common for me to do. Because if you think of a dog that came in for being ill, probably they're lethargic. So you already have at least one sign there. And to have the blood work and have mild neutrophilia, elevation of some GGT, that's really not an unusual scenario. And you take a look at everything on this list, to have two of these, it's not hard. Now, some of them are a little bit more, specific and dramatic, right? Radiographic findings with pulmonary hemorrhage syndrome, that's not a mild clinical sign. That may spark your thoughts. But again, often we think of lepto as, oh, it's a liver kidney thing. This is a lung issue. No, we need to be running it for those too. And that's why for me, often if you're not doing well, I'm at least trying to screen this disease out. ACVIM puts into two big categories when we talk about cases. We have what's called a supportive case and a confirmatory case. Supportive case, MAT titers greater than 800 in at least one of these serum specimens. IgM, this is going to be your point of care test. There's a couple companies that make different in-house lepto tests. The test, and we'll talk a little bit more about it, but there's one company that does IgM that's very common, one that does IgG. The pathologic leptospires in urine, C, that is going to be your PCR. The problem with that, and this is one of the things I had a long conversation with Dr. Sykes on, was to me, if I have a sick patient and I have positive PCR in the urine, I'm like, isn't that enough? And she reminded me that a lot of times, yes, that does mean that we have a pet that needs to we need to get rid of the bacterium in its body. But because many times the dogs can be acting as a reservoir, that doesn't mean that we are, that the presence of that bacterium is what is causing those clinical signs. And that is the reason why urine PCR remains by itself just a supportive indicator, not a confirmatory. To get true confirmatory, we are going to be looking at that PCR of the blood. But remember, that bacteria, it's a very romantic bacteria. It just wants to go find its home and have children. That home is in the kidneys, not in the blood. So it's going to travel. There's going to be a small period of time where it's in the blood, then I'm going to move to the kidneys, and that will see a transition over to the urine. So there's a very small window of time where we can be lucky enough to get that blood PCR. If you're sending out a PCR, absolutely, you want to always run blood and urine together, increasing that chance of what you can diagnose. Just a quick review on some of these tests. The MAT test is the kind of the gold standard when we take a look at it. It's great because it can give us an idea of maybe the serovar, which could give us some importance if we're having outbreak, where did it start, where, what to do about it. With MAT testing, it is great. Working in an ER setting, I will tell you though, I don't run this test. It's very expensive. It's often needs to be paired. And so for that reason, it's just for where I practice and the type of practice I do, I actually do not run these. But it is considered to be one of the best tests that are out there. PCR. PCR is what I will use as try to confirm it, but it can be challenging. When we take a look at PCR, again, if you are lucky enough and you have a leptospirosis patient and it also tests positive in the blood, you're done. It's easy. It is most likely that if you have the clinical signs, changes on the blood, you have a positive blood PCR, it is very likely that the signs that you're seeing are also secondary to this. Go ahead and treat, and that would be a supportive case. However, if you have a negative blood test, that doesn't mean that it is not lepto. It may have moved out from the blood into those kidneys. If you have a positive urine test, often that does mean that we do have lepto in that patient. It may or may not be directly related to all the signs that you're seeing that day. And finally, with a negative urine test, there can be intermittent urinary shedding. A lot of times there's isocyaniria going on, and so there can be a number of reasons why you wouldn't see it. Or if the patient had been on some antibiotics, that can also lead to that as a negative. Point of care tests. The two main companies that we often see, one is an IgM. The advantage of IgM is, of course, it is that pentamer antibody. It comes up earlier in infection. Because of that, it's a great way for pets that are sick early on. If we're able to test them early on into the signs, IgM is a great way of testing. When we take a look at IgG, again, when you have an amnestic response to anything, be it a pathogen or a vaccine, you're going to start with that IgM and then transition over to that longer term IgG. So for animals that are sicker for a longer period of time, or there may be a reservoir, you're going to have a higher rate of catching that on an IgG. Challenge is neither one of these are DIVA tests. The PCR is a DIVA test. Remember, of course, DIVA is differentiating infected versus vaccinated animals. PCR is a DIVA test. These point of cares are not. Based upon the fact that an IgM is an early rise, IgG is your longer, you are going to have worse false positives with your IgG. Ideally, I wish that these companies would actually make combo IgM IgGs. I think that there'd be a lot of value to be able to look for both of those. Right now, the most common test out there, Zoetis's Witness Lepto, is the IgM, the one on top, and the IDEX Snap is the IgG. There's pros and cons, again, to using for both. If we have early symptoms and a dog that was maybe more recently vaccinated, that's going to be a much more clear Zoetis Zoetis Witness test. Sorry. If you have a patient that's been either not vaccinated or has been overdue and maybe been sick a little bit longer, you're going to have a much better chance of finding that on an IDEX snap. And it, again, for those reasons why I wish that both of the companies would come out with a combo to be able to look for both IgM and IgG. So here's a case. This was an actual case. 10-year-old little poodle came in for some chronic ear infections, a little bit of inappetence, so some hyperexia, just not feeling great. This is one of the patients I saw. This was the blood work. We had a little bit of an anemia going on, or non-regenerative anemia. We had leukocytosis, neutrophilia. So that gives us at least one, right? We have one clinical sign. We have, or two, I'm sorry, lethargy and hyperexia. And now we have at least one of the sign, changes on the blood. We have neutrophilia. We take a look at the blood, and we also see when the liver enzymes on that list as well. But again, I don't know about you, but when I take a look at this, this does not appear to be the face of lepto blood work, right? So what do we do? It has enough to maybe make us think about it. So what tests would you recommend? And I do apologize on this. The second question, that should be $196, not 96. But that would be, I pulled those off of our costs at the ER that I work at. So I love it, right? All of these are great answers. And you know what? Maybe, depending on where you live, the geography, maybe this isn't something that you want to think of as a lepto case. Depending on what you can run, this social economic status of the client, there's a lot of different factors that go in. For us, I did run a point of care test that was positive, and then we followed it with a PCR, and that was also positive for that pet. We talked a little bit too about what do you do with that IgG, and that's what we had with this patient, right? So this was not on the list in the ACVIM, right? They want an IgM because that's going to be more temporally associated with clinical signs and infection. And the urine, positive urine, it absolutely fits as a supportive case, but it's not confirmatory by any chance. So what do we do with that situation? You have a positive IgG, positive urine. Dogs, probably should be also looking it up and working it up for that anemia that may be more important than what's going on with the lepto for the dog. But what does that mean? Well, it does at least prove that both prove exposure, and the urine PCR means that we have lepto. This is a disease that's zoonotic. We need to be treating this dog for it. Do we need to be looking for other things that are going on? Comorbidity? Yes, absolutely. But when we do have this combination, that does mean that we do need to take action. So here's another thought. Let's say your hospital, you have some ability, you're at a 24-hour or there's a weekend and you have hospitalization. You have a 7-year-old poodle. It's had acute renal failure, some signs of vomiting. You have some kidney issues, leukocytosis. Owner wants to hospitalize. What do you do? Again, before I became medical director at the ER hospital, we weren't running it. Now we recommend it. And again, my recommendation to my doctors is I tell them I would require it, especially for the point of care tests. Zoetis and IDEX have made these tests very affordable. Why not be running this as a screening test? Because it's there to protect our staff as well, right? And all the other patients there. So I think having this on front of mind, we will start to see it. When I joined the emergency center of Redlands, that they were seeing 1 to 2 positive tests per year. Since I have taken over as medical director there, we are seeing 1.2 positive tests per month. And that's just because we start testing a lot more for it. Now, again, does that mean that they were all lepto? Again, some of that can be exposure. It does mean that all of those pets likely were exposed. We need to talk to them about possible treatment, definitely protection for them and their other pets. So it's one of those that if we aren't looking for it, we're not going to find it. And now that the tests are a lot more affordable, we need to be running those tests. When I took a look at a couple months of our patients and I just looked at weight and age, what I learned was everybody is at risk, right? If you're a happy dog living an active, happy dog life, that means that there's exposure to lepto. And in the area of Redlands that I work, very few people vaccinate their pet. And this kind of supports that. So what do we do with those cases too, where we have a positive point of care test and either the client says, no, I don't want to pay, or we send out PCR and it's negative. What do we do? I still treat them. Not always, right? There's some where you have to take each case independently, but as a general rule, if it is a question in my mind that this could be a positive lepto, I am much more apt to treat. Because worst case scenario, I'm hospitalizing the patient, diuresing them, putting them on antibiotics, and all my staff is wearing proper PPE and doing careful handling. If I'm wrong, I can live with that. And many times they're going to get better just based upon that. It treats a lot of things. If we look at the other worst case scenario and we say, well, I really want to be good on my antimicrobial stewardship. I don't want to overuse it. We have to remember that worst case scenario of a failing to treat a true lepto case would be a human infection and or death. So I think for those, again, if I'm concerned about it, I will be more apt to provide antibiotics, diuresis, but always keeping an eye out that there could be something else going on. In today's world, right, balancing antimicrobial stewardship is very important. With that, though, I did just want to balance out what is done with doxycycline and antimicrobial stewardship in the human world. In the human world, they just throw it out at almost everyone. It is kind of scary. If you have acne, they can just put you on it. If you have rosacea, you can be on lifelong low-dose use. There's also doxy-pep. If you have multiple partners, your doctor can just give you a bottle of it, use it as needed. So on the human side, we throw around doxycycline with a fair amount of regularity. And so I feel if there is a patient in front of me that I have some justification that I could have a deadly zoonotic disease, I am very comfortable putting that patient on a course of doxycycline. So here's another case. We have 8-year-old male neutered old dachshund. Now this guy was presented for a lepto test. He said, hey, my dog is totally normal, but you just saw his sister. She was at the hospital. We spent a few $1,000s. She was really sick with lepto. The doctor tested for lepto and it was positive. But again, the rest of the blood work was totally normal. So this would not satisfy a supportive or confirmatory test by itself. So what do we do if you have a supportive or suspected case in the household? What do you do with all the other pets that are there? Yeah, so I like the different answers. Again, I don't know that there's necessarily anything. There could be a lot of different approaches. For me, it's prophylactic antibiotics. I would not have even I would not have even run the point of care test on that dachshund. It's there. It could be a reservoir host. We clearly have lepto within the other dogs. They're all together. I want to make sure that any dog in that household is on doxycycline. I want to make sure that we can help say, let's start from a clean slate. Let's get everybody on the vaccine and get everybody educated about leptospirosis. So for me, I do not. Again, depending on your client, they may want to say, oh no, I want to run those blood work. I want to run everything else. I think running a CBC chemistry on any pet is always a great idea, because even if it has nothing to do with leptospirosis, we may uncover other things as well. But if they don't have the money to do that or not inclined, I just put them on, everybody on doxycycline. So in all the cases that I have diagnosed over the last couple of years of lepto, this is the only case I ever called it. I will tell you, every time I look at a case and all my technicians are like, so doc, I bet you think this is lepto, right? I'm like, yes, which is why we'll be wrong. Most of the time when I pick up lepto, we look at the history, we look at the blood work after the fact, and we say, oh, wow, this actually does support that. But this one was an interesting one. It was a case that was being handed over, and this dog, it was a cane corso. The poor little guy, we kind of knew he was dying because he was normally pretty aggressive, as a lot of cane corsos are. And this little guy was just like kissing all over everybody. We're like, this is not looking good. We did have a lot of heart changes. This dog was laid out. Chest x-rays were, and abdominal x-rays were normal. ECG was abnormal. Ultrasound was normal. PT, PTT. We had other tests pending, but when we take a look at it, we did have that elevated creatinine as well. We also had some changes on the blood, and by far it was positive. Remember, with supportive cases, we're wanting to have 2 or more of those clinical pathologic abnormalities and those clinical signs. And then we can run an IgM and PCR or MAT. Last patient, this was a little 7-year-old male neutered terrier, came up kind of acting weird, panting, uncomfortable, seemed to not be feeling too well. We went ahead and ran the blood work. This is the blood work that we see. So not really too exciting. Some changes on those electrolytes. Did come back as positive when we took a look at the IG by ELISA. So we did have a positive lepto. When we sent it out for PCR, though, it was negative. In this case, we chose not to treat. This was one where we did have a positive in-house. However, we did not really have a lot of exciting clinical signs, but really the basic blood work was not consistent with it, and the PCR was also not consistent with it. So just because we do have it, it doesn't mean that we're going to be treating every case. I've had a couple doctors that have reached out to me that say, okay, I've been to one of your lectures. I love the fact that I should be running a lot more tests, but I'm running all of these in-house tests and they're all negative. I feel so bad. I feel like I'm wasting my client's money. So my response to that is, when you run an FELV-FIV test or 4DX test, do you feel bad when they're negative? I mean, I feel pretty happy when they are. We've screened for some very serious diseases. And if we take a look at FELV, FIV, heartworm, Lyme, or Ehrlichia, what's the one big difference with that lepto test? It's zoonotic. It's directly infective from the patient to the owner. We should be running a lot more of these tests in-house. And if we get a lot of tests and they're all negative, well, by gosh, celebrate into your negative test, lean into it. Just because we're having a lot of negative tests doesn't mean that we're wasting the client's money. And it's something that we should be, again, leaning into those negative tests and being happy with them. So again, in summary, leptospirosis, the vaccine is considered core or core-ish by ACVIM, UC Davis, AHA guidelines, CDC. Screening tests, if you're in clinical practice or talk to others that are, again, we need to be running a lot more of these in-house tests. You can reach out to your Zoetis and IDEXX rep to find out what's best for you. Consider those confirmatory tests. They're going to be a little bit more expensive. That's why I love the screening tests on the front end. And again, consider treatment case by case. We always need to be good at our antimicrobial stewardship. But remember, on the human side, they throw doxy a lot out for lesser reasons. If I can potentially save a human or dog life, I'm going to do so when I can. So with that, I will open it up for questions. I'm going to stop sharing here. And Eric, what?
Yeah. So we will move into some questions right now. Have a question, kind of a three-part question from an individual. First of all is, do you see subclinical cases that may have mild symptoms but elevated renal and liver values?
Yes. With those, again, working ER, I see less of those, but I do see animals that come in for other things that are ADR. They're coming up positive, especially if we can get a positive urine. That is then a recommendation to treat. I think one of the cases that we had reviewed had that anemia that was probably unrelated and something that we definitely needed to work up.
Right. Same individual asked about, positive point of care tests from prior vaccination. Do you have any experience with that?
I do. I don't want to speak for the companies though. So I do reach out to whichever company that you have. As a general rule, the IgM is going to have about 25% false positive after the first 3 months. 3 months after vaccination. The IgG test, you can have false positive all the way up to the end of a year. That does become a challenge. In a diagnostic way, I'm lucky that Redlands really doesn't have a lot of vaccination. So our IgG, it's a little bit easier to read that there was clear exposure. If you have a vaccinated population, though, that is it becomes a little bit more of a challenge. Your IgM is going to have less false positives with vaccination, though.
Okay. And finally, so it was a three-part question. Anything about asymptomatic shedders? Should those be screened for and treat those to prevent spread?
See, I love that. I wish, there was a way where we could just do screening for everybody, right? If we could get a cheaper urine PCR, my gosh, I would just have that as a basis if walking in for your annual examination. I absolutely would be doing that. I think we need to be looking more for it. It is out there.
Okay. Shifting species a little bit, do you routinely test and preemptively treat cats that share a household with a positive dog?
Okay, I feel I feel like I'm going to let down all the cat practitioners out there. For as much as I love leptospirosis and looking for it, I'm really bad about looking at it for cats. It's challenging. When I have brought it up about urine, it's just so expensive. It just doesn't get done. I wish that we had more information on it. I think that there's a lot of cases that I'm sure that I have missed and potentially let down those patients because of it. But the fact is we really don't have all the information on cats and leptospirosis. To some degree, they have higher level of resistance than other species, probably because they're eating a lot of lepto out there. So a little Darwinism.
All right. You presented data that indicate 1 in 3 brown rats harbors lepto. Is there any similar data for beaver, mice, other rodents, squirrels, etc.?
There are, when we take a look, it's actually kind of nice because it's one of those where if you're doing wildlife prevalence, you can go out, grab a bunch of animals, and harvest kidneys. It's wildlife don't like it, but it does make it fairly easy to do. So there's a lot more information out there. When it comes to rats, that's definitely one that we have so many studies that when we patch it out globally, there's a lot of information. When I've looked at data on, say, sea lions or um, sea lions, mice, some raccoons, things like that, they're usually a much more smaller demographic. But there's a lot of data out there. Um, Interestingly, there was recently a study in Southern California. I don't think it ever got published because they just weren't finding it, even though then within 2 years, that was when we had one of the largest outbreaks of the country of leptospirosis. But at the time, we weren't finding it. So it can be a little bit hit or miss too.
All right. Um, kind of shifting a few questions about the various serovars of lepto. They can be geographically related, but any thoughts on what the most common serovars we're seeing in dogs across the U.S.?
Yeah. As we do a lot more testing, in-house testing and PCR does not give you the serovars. When we do mat testing, it's hard to get the two paired samples, and it's not always accurate on serovars. So when we take a look at some of the prevalence studies that we talked about before, those they've worked harder to identify more accurately what was going on. When we had the large outbreak in Southern California across 3 different dog boarding facilities, interestingly, the thought was that it was a Canicola serovar. I will say from a clinical standpoint, I don't really worry about the serovar because I'm going to diagnose it and treat it very similarly. There are some good studies out there that do show that depending, like Pomona often has more serious clinical signs than, say, Canicola. And they will also say that which serovars are going to have more likely to have different clinical signs. And yes, there's definitely a geographic difference, but if you ask me for specifics, I do not have that in my brain.
Okay. Common thread in the next questions, the efficacy of vaccines and the impact of cross-reactivity of serovars, how that may affect the efficacy of vaccines.
Yes. So there is a lot of cross-reactivity. There was one study, and I do not remember the name, but they had taken dogs, given a vaccine that had the 4 serovars, and when they ran mat testing, it was very common to have the highest serovar was autumnalis, which is not in the vaccine, nor have we ever really established that it infects pets. So there is definitely some cross reactivity and challenges there. That's why, again, if you end up having a mat test and it's something that's outside of the vaccine, that doesn't necessarily mean that is not a false positive from the vaccine. The vaccines, they work very well. If you've listened to Dr. Sykes speak on it, again, she says that with those, if they are being vaccinated up at UC Davis, those are not the dogs that are kind of melting in front of you, that the vaccine works well. In addition to that, remember that all of the 4 big companies that make vaccines, inside of each vaccine, it's like a little insurance package popped inside. Most of those companies will, if they're properly vaccinated, up to date on lepto, will financially support those customers for up to about $5,000 is kind of a typical ballpark for that. That has saved many lives at my hospital. We give them a $4,000 estimate to get started on their lepto case. They're like, let's put him to sleep. Like, hold on. Let's look at the vaccine status. If they're vaccinated, we've had the companies step up. One case, actually, Zoetis paid $10,000. That owner was not out a dime for the treatment of her pet.
Okay. We'll do just a couple more, and I'm kind of going to lump uh, two or three questions into one, moving over into more of a One Health type of a arena. Any correlation between what you're seeing in your clinic on the point of care tests or other testing and human cases in your area?
Mm.
Um, in your hospital staff, hopefully not, but can you comment on that?
Yes. So for the last 15 years, I've actually worked at biopharmaceutical companies, and that allowed us to really interact with a lot of veterinary hospitals across the area. And when I was working and covering the greater LA basin, we did have some hospitals that at the time that they had pets with leptospirosis. There were technicians that also got sick, had been at the hospital, and were diagnosed with leptospirosis. Um, when we take a look at where most people are getting exposed, most human cases in the United States, it's all happening over in Hawaii. It's a has a great environment to breed leptospirosis. If you're looking at the most of the people, we are going to be exposed if we're in our field of work, or if you're working with livestock. Um, those big animals, if they are infected, they are producing large amounts of volume. So the average pet owner, less so exposed.
Okay. And we're going to finish up with a question about vaccines and um, you know, as far as you mentioned that vaccine uptake and using your clients sometimes are hesitant to be vaccinated, whether it be due to cost, whether they believe it's a dangerous vaccine. Any good talking points, advice on how to turn that ship around and
Yeah.
convince people that it's the right thing to do?
Yeah, I think, the talking points for me, it's very quick of, if your dog's living a happy dog life, it's probably exposed to leptospirosis. It doesn't really have, another name. I wish it did, Mrs. Jones, but, now if you take a look at our larger, recommendations from our AHA, UC Davis, they're recommending it, but even the CDC is now recommending it. So it is a change. And I know that you were recommended from your breeder not to give it because of concerns of reaction. And your breeder was absolutely correct about 20 years ago, but that data has really changed. These vaccines are very safe, and that is why it's recommended. So that's kind of my quick talking points. I can usually get the vast majority of people to vaccinate. And now more and more, the boarding facilities are helping us out because definitely in LA, when they have a massive outbreak of it, they are now requiring it.
All right. Excellent. Well, I want to, we're at the top of the hour, and I want to, first of all, thank Dr. Lee for a fantastic presentation. I was telling him before the webinar that this was a banner presentation for registrations. It broke a record for our ACVPM continuing education program for registrations, and it also broke a record for attendance. One time we had over 250 attendees. So that's a testament to the topic, the interest in the topic, and after seeing the presentation, it was a testament to the presentation. Very well done, and we appreciate the excellent presentation. Um, Close out, that we can't do this without gracious volunteers such as Dr. Lee. So please, if you're interested in providing a presentation at one of these webinars, you can contact you can contact me at admin@acvpm.org. I'll get your proposal to our continuing education committee. You can also go to our ACVPM website that has a continuing education tab right on the main page, and there's a way that you can submit your proposed topic to our continuing education committee. So I definitely want to thank you once again, Dr. Lee. I want to thank everybody that attended. Please keep an eye out for an invitation to our next CE webinar, which should be, I believe, on the 25th of September. That should come out in the next couple of days. So everyone have a wonderful day. And finally, again, Dr. Lee, fantastic job and thank you very much.